Today's topic is obesity. Two points are there. First is definition. Second is problems associated with obesity. First, I want to concentrate on BMI because many of us ask first thing patient do is what is your weight? Weight is just a number. It should be compared with height. So importance is weight is not only important. BMI is more important. So BMI is weight upon height in meter square. You can open Google and you can self in just one click BMI calculator. It will be first two three links. You can open enter weight, enter height, and calculate BMI. So normal BMI is 18.5 to 25 is current WHO criteria. Our Asian criteria is more stricter, but we will discuss only this one right now. Overweight is BMI 25 to 30. 30 to 35 BMI is class 1 obesity. 35 to 40 is class 2. And more than 40 BMI is class 3 or morbid obesity. These are all three are for undernutrition. That is currently decreasing in India. And this overnutrition or obesity is currently increasing in India. Three persons, same height, but weight is different. So their BMI is different. So if you ask only weight, this person weight is 140 lbs, this person weight is 220 lbs. If you compare height, then you will know the BMI. This patient BMI is 23 is normal, and patient's BMI is 36. Obesity is a root cause of multiple comorbidities. Globally, obesities are increasing. If you see incidence according to year in 1980 and compared with 2010, is data is I think around last data is 2022 WHO data 764 million, around 76 crore adults are live with obesity. 39 to 49% world's population are overweight or obese. Particularly if you talk about the urban population, 73% population are overweight whose BMI is more than 25. 100 out of 73 people are overweight and 100 out of 33 people are obese whose BMI is more than 30. Life expectancy decreases with increase in BMI. If you calculate chances of reaching age of 70 year, with normal BMI it is 80% chance, but with BMI 35 to 40 it is 60% chance, and more than 40 means morbid obesity chance is only 50% to reach 70 year. So it is a higher morbidity and mortality. This is a whole spectrum of diseases associated with obesity. Pulmonary disease, very common OSA, hypoventilation syndrome. Then NAFL, non-alcoholic fatty liver disease, starting from steatosis, steatohepatitis to cirrhosis and maybe malignancy, whole spectrum. Gallbladder disease, gallstones, gynecological problems, abnormal menses, infertility, PCOD, urinary incontinence. As we know, ONE, many patients, obese patients have unilateral bilateral TKR. Frequent fungal, bacterial, skin, genital infections, gout. Then right side, starting from upper side, cognitive decline, mental health conditions like depression, stroke, cataracts, whole metabolic spectrum, coronary heart disease, diabetes, dyslipidemia, hypertension. The renal failure, around 60% patients of CKD or who are progressing to dialysis or transplantation are diabetic and hypertensive patients, which is also a spectrum of obesity. Then cancer, multiple cancer, breast, uterus, cervix, colon, esophagus, pancreas, kidney, prostate, and DVT. This is a complex mechanism of how these all complications are arising from obesity. Obesity leads to increase all metabolic derangement is done by increase adipokine synthesis, increase lipid production, increase activity of RAS, and mechanical stress. This all combined producing all particular mechanical stress is producing OSA, ONE, and GERD lead to at last adenocarcinoma. In chronic diseases, coronary heart disease, chronic heart failure, stroke, CKD, NASH, CLD. These all diseases are directly related to increased lipid production, and these are the enzymes increase pro-inflammatory cytokines lead to increased insulin resistance and type 2 DM. These all things lead to endothelial dysfunction and increased chance of atherosclerosis and chronic diseases. Consequences of inflammation in obesity. It increases endothelial permeability, increase plaque development, decreased cholesterol metabolism, increased glucose production from liver, and decreased glucose uptake, and increased insulin resistance from muscle, and decreased insulin secretion. This all spectrum lead to coronary heart disease and type 2 diabetes. A link among obesity, inflammation, and CVD. Ectopic fat. We can say fat or ectopic fat means obesity as a cancer. This is a very hard word, but we can say it a reversible cancer, because obesity produces so many diseases, and it is all these fat is ectopic, that is not originally present there. If we go for weight loss, then all these hypertrophied adipocytes come back to normal. These are body size, metabolic status, and CVD events. Patients with higher BMI have increased coronary heart disease. As you can see, patients with normal weight, overweight, and obesity. Obesity has highest chances of CAD, highest chances of cerebrovascular disease, and highest chances of heart failure. These most patients we are currently seeing in our OPD setup. And with diabetes, this risk multifold increases of vascular deaths and non-vascular death. Both if patient has diabetes and no type 2 DM, with type 2 DM, this whole mortality and morbidity increases. Weight loss effect on CV mortality. If a patient two arms patient, one is control and one is intervention. If you see intervention arm, they have decreased CV mortality, and if control nothing is done, then they have higher chance of CV mortality. She is showing the same results. Look ahead trial, it is showing association between magnitude of weight loss and increased incidence of CVD in patient with type 2 DM. If we have significant weight loss, means around more than 10% weight loss, then our hazard ratio is decreasing from 1.1 to 0.8. So these are significant differences seen when weight loss is around 10 or more than 10%. This is how there is a gut brain connection in obesity. As people are not, they don't want to produce obesity by themselves, but there is a hormonal mechanism, there is a satiety mechanism by they have increased hunger. Hormones such as GLP-1, PYY, leptin, ghrelin, these nutrient related hormones that impact brain and regulation of weight. Overall, targets toward greater weight loss and overall health improvement. If we see all these conditions are produced by obesity or increase in weight. So how this hypothesis is proven? If patient goes for weight loss, then all these conditions are reversed. Most of the conditions are reversed, and some conditions progression is halted. Like osteoarthritis knee, we cannot reverse it, but this progression can be halted by weight reduction. But many diseases like we have listed in last academic phase, diabetes can be reversed with weight loss. CAD, CVD can be prevented. Further episodes. So 0 to 5% weight loss, hypertension and hyperglycemia goes back. 5 to 10% weight loss, type 2 diabetes can be prevented. Now, for PCOS, dyslipidemia can be prevented. If we go for 10 to 15% weight loss, as we have seen last slide, then cardiovascular disease are also prevented. OSA, GRD, ONE also prevented by this 10 to 15% weight loss. And if we go for more than 15% weight loss, then all our body benefits are added, including heart failure incidence also reduces. Obesity and brain, there is a stress factor is there. Many patients have stress eating. They in stress condition, they therefore binge eating. So it acts through frontal lobe executive function. There is a hypothalamic hunger system, and there is a metabolic reward system. Metabolic reward system hormones are dopamine, opioid, cannabinoid receptors. If we are in a happy situation, then we don't go for binge eating. So these hormones play a much important role in our eating patterns. Psychological, so there is a cognitive behavioral therapy. Patients patients are stress associated binge eating. Then if we go in root cause, what are the stress factors? Then if we modify that, then patient can change their eating pattern, and obesity and weight loss can be progress to there. There is one case is there. Female 47-year works part time in supermarket, 2 teenage children, non-smoker, rarely drinks. It is almost, I think, US case. Asthma, irregulars having PCOS, gestational diabetes. Last recorded weight was 105 kg 5 years ago. Medication on asthma medications. CS are routine complaints: fatigue, general headaches, pain, sometimes breathing difficulty because of overweight, obesity. Blood pressure is also higher side, 150 by 900. Weight is 126 kg. BMI is 42 kg per meter square. No other complications are present at that time, at current time. Patient concerns to you in OPD. Would you raise the issue of weight with her at this status? What investigations would you done at this point, and what other conditions might you consider looking for? So, if we can only comment by about weight after only calculating BMI. If we saw only gross weight, we can't comment patient is which stage of obesity and which therapy to involve. A1C is 6.4, so 5.7 to 6.4, the C is diabetic. Cholesterol is higher side, LFT normal except SGPT is 56, as we are saying in most patients. SGPT is higher side who are NAFLD with obesity. 24-hour BP confirms hypertension fluctuations are there. Means there is an increase in BP and sometimes is there. So diet and lifestyle advice, refer to diabetes prevention program. A1C is 6.4. It is just starting of diabetes. Statins, so patient don't wish to take statin at this time because there is also reversal of dyslipidemia also chance. Antihypertensive, we will put on antihypertensive. We will not take risk for sudden hypertensive emergency or any complications. We can withdraw it later on also when patients develop reversal. Diabetes prevention program online, CS lost 3 kg weight, VP improved on current on ACE inhibitor, A1C 6.4 same, unhappy about the rate of weight loss. Ask about the further weight loss medication. These weight loss medication will discuss Dr. V. Patel. So after this result, our weight is reduced 108 kg from 126 kg. More active, walking a dog every day, breathing is better. BP is also control 128 from 150. A1C is 5.6. She is much happier and wants to continue with medication, although no longer losing weight. The patient may have plateau phase in weight loss. And initially, there is a good weight loss, and so, for some time weight loss are stagnant, but there is each loss is present in almost all patients. So these are pattern how there is a gross function like diet and lifestyle. Then we add pharmacotherapy, then gastric sleeve, gastric bypass. We will discuss in next session. There is basic is three. First is lifestyle, then pharmaco, and then surgery. If obesity is higher side grade, then we are including further steps. Here's a class recommendation for overweight or obese patient to weight loss or not. All are first was class 1A recommendation for prevention of type 2D, DM, and CVD. This is our last slide. It is showing that how much percentage of weight loss produces how much benefits in body, 3 to 10%, 5 to 10%, and 10 to 15%, that we have already discussed earlier.